Thanks to everybody for joining. We are really excited to be holding this webinar on value assessments, the impact on people with rare diseases. My name is Sarah Vangertruden, and I am the Executive Director of the Partnership to Improve Patient Care. I want to thank everyone who's joined us today to learn about value assessments and their impact on people with rare diseases. It's important to understand how value assessments work because they are more and more being referenced in coverage and reimbursement policies. Daniel, can you move the slide forward? Thank you. So PIPC was established to advance principles of patient-centeredness in an evolving healthcare system. And to be truly patient-centered, we believe that patients and people with disabilities must be engaged partners. PIPC advocates for the voices of patients and people with disabilities to drive the research that forms the infrastructure for meaningful shared decision-making and improved healthcare decision-making. And we work to ensure that patients are at the table with policymakers in the development, implementation, and evaluation of alternative payment models. PIPC also recognizes the need to advance patient-centered models for the development of value frameworks, which is why we're here today. Ultimately, our goal is to ensure that value in healthcare is defined as achieving outcomes that matter to patients. So I'm not sure why I'm having trouble moving there we go. So Tony Coelho is PIPC's chairman and also a patient with epilepsy. It was Tony's epilepsy that brought him to author the Americans with Disabilities Act and to continue to fight for a seat at the table for patients and people with disabilities and their families. So in this age of personalized and precision medicine, Tony knows personally that no patient is average and that healthcare cannot be one size fits all. So we're excited today also to have joining us Ari Namer. Ari is going to talk to us next about a metric called the quality adjusted life year that is often used by payers to assess the value of treatments. Ari's been part of the PIPC team for a long time, first in his work leading the Autistic Self-Advocacy Network and now as a consultant for PIPC. So thank you, Ari, for joining us.
It's my pleasure. Thank you very much for having me, and thank you all for joining this important conversation on ensuring that people with disabilities and people with chronic illness have access to the care they need. If I can just ask Daniel for you to go to the next slide and the slide after that. The quality adjusted life year is a metric used to assess the value of particular medications and other healthcare interventions that has been adopted by the United Kingdom and a number of other countries and has become a topic of increasing conversation within the American healthcare system. The essence of the QALY is something called a disability or utility weight, which assigns a discount to a year in the life of a person with a disability, seeking to quantify precisely what percentage of value a year in a disabled person's life has relative to a year in the life of a hypothetical non-disabled healthy adult. So next slide. 0 would constitute death. 1 QALY would constitute a year in perfect health. And the function of the disability or utility weight, next slide, is to calculate the precise percentage that a year in the life of people with particular conditions has relative to a year of non-disabled perfect health. So here we have a list of disability weights for a variety of conditions. If we look at the bottom of the screen, rather the middle of the screen, you see that mild multiple sclerosis has a disability weight of 0.183, meaning that a year in the life of a person with mild multiple sclerosis is worth approximately 82% of a year in the life of a hypothetical non-disabled healthy adult. If you look at severe multiple sclerosis, you see a disability weight of 0.719, meaning the year in the life of a person with severe multiple sclerosis is considered worth approximately 30% of a year in the life of a non-disabled healthy adult. And I don't seem to have slide control, so I'll ask Daniel to, no, I do have slide control. And we see this with other conditions as well. Bipolar manic state has a disability weight of 0.49, meaning that a year in the life of a person with bipolar disorder in a manic state is considered worth approximately half a year in the life of a non-disabled person. And you can see why disability rights advocates would have a problem with the quality adjusted life year, because there are all kinds of issues that materialize when using the QALY to assess the value of particular medical conditions, especially for people with disabilities and chronic illness that are not likely to have their condition entirely cured via treatment. If you have a condition, as is the case for so many people with rare diseases or rare disabilities, that requires ongoing treatment and ongoing management, then the nature of the utility weight is that life extension will be undervalued. So if you have a condition that has a utility weight of 0.5, meaning that a year in your life is worth half of that of a year in the life of a non-disabled person, then if a drug would extend your life by 10 years, it would only count as extending your life by 5 years. And even non-life extension properties like quality of life improvements, restoration or improvement in functional skills or abilities are measured through the use of these utility weights, which are often calculated through things like telephone surveys of the general population, asking people, would you rather have 5 years of life with condition X or 10 years of, or 2.5 years of non-disabled life? And part of the issue with that is that non-disabled people often have distorted impressions of living with a disability. We see that members of the general public often report that they would rather have a terminal illness rather than be blind. Under some quality measures, conditions like inflammatory arthritis are rated worse than death. There's a long-standing issue in disability and chronic illness community circles where to have a condition is often perceived as worse than to live with the condition is often perceived as worse than to end one's life. And so that creates a problem when we are calculating disability weights based on the perceptions of the non-disabled public. Now, one of the other issues that we run into is even if quality adjusted life years are calculated based on surveying people with disabilities rather than surveying the non-disabled public, we still see some very severe problems with the model. This is a quote from Peter Singer, a very prominent bioethicist that many in the disability community have problems with on any number of areas. Singer argues that if we were to survey people with quadriplegia and find that they would report that they would not give up 1 year of life as a person with quadriplegia in order to have their disability cured, then the QALY method does not justify giving preference to procedures that extend the lives of people without disabilities over extend the lives of people with disabilities. Essentially, if life with quadriplegia is as good as life without it, there is no health benefit to be gained by curing it. So QALYs, by virtue of combining morbidity and mortality into a single number, mean that if your condition does not have a disability weight that requires you to undervalue life extension, then you will not have the opportunity to value quality of life improvements emerging from a particular healthcare intervention as well. So part of the issue that we're running into here is qualities force a cruel choice between life extension and quality of life improvement. And that's usually not how most people with disabilities see themselves or prioritize their health care. Most people with disabilities generally want to live longer, and they would like to have their quality of life improved at the same time. One of the solutions that's been proposed in discussions around quality of life years are the equal value for life year gain system, the EVLYG. The EVLYG was recently proposed by the Institute for Clinical and Economic Review, which you're going to hear a little bit more about later from Sarah, as a solution to the problem of QALYs undervaluing life extension for people with disabilities. I'm going to talk a little bit about why EVLYGs don't actually solve the problem of QALYs. And once again, I don't seem to have access to controlling these slides. So Daniel, if I could trouble you. Okay. And again. So the EVLYG functions as a supplementary measure to the QALY. Essentially, the equal value for life year gain system adds an additional measure on top of the QALY that does not discount the life of a person with a disability when assessing how many years of life extension a particular drug or medication may provide. This partially mitigates the extent to which QALYs undervalue life extension for people with disabilities if insurers use EVLYG. One of the things we've seen from a number of reports from ICER and other entities that use QALYs is that insurers and other payers will often pick whatever number justifies the most restrictive possible interpretation of whether or not they should cover a intervention or treatment. And so it's entirely possible that the EVLYG may be made available and insurers will ignore it. But even if we accept that insurers will use the EVLYG as a supplementary measure, ICER and other entities that use the QALY and the EVLYG together still rely on the use of the QALY and the disability weight to ascertain whether or not a drug provides benefits for quality of life improvement. And the EVLYG doesn't really address the problem that we're relying on this very blunt instrument that tries to translate the many complexities of individual conditions into a single number, the utility or disability weight, for assessing whether or not a drug provides quality of life. Next slide. Next slide. So we talked a little bit about the idea that under the QALY system, different conditions are split into broad categories of severity in order to assign disability weights or utility weights to each. And usually what's used is some combination of mild, moderate, and severe. You see it here for multiple sclerosis, epilepsy. Next slide. But when we talk about condition-specific metrics, conditions often have a lot more complexity than mild, moderate, or severe. So this is the Expanded Disability Status Scale, which is a metric often used in the context of people with mobility impairments, including multiple sclerosis. And what you'll see is that it has a wide variety of different scores reflecting the extent to which people have improvements or reductions in functional skills with regards to mobility. There are very few people with any condition who, if you ask them how they're doing, would say mild, moderate, or severe. And if we have a quality-based system, improvements within the mild category or within the moderate category may not be counted in the event that they do not shift from moderate to mild or from severe to moderate, even if they result in improvements in people's actual quality of life and lived experience with a particular disability. Next slide. Next slide. We see something similar here with depression, mild, moderate, major. Next slide. If we look at depression-specific rating systems, then one of the things we see is that there's a wide variety of different ways that we assess quality of life in depression. And so we face this really severe challenge here where under the quality system, modest improvements in quality of life that may be extremely important to a person with a disability are not counted because they don't move someone from the severe to moderate category or the moderate to mild category. Next slide. Next slide. Finally, I want to highlight that one of the other difficulties we see with the quality system is that it relies only on what's been reflected within the research literature to date. But for many people with rare conditions, the research literature may not reflect different subgroups. For example, we know that women, people of color, people with disabilities, and others are underrepresented in a lot of the research literature that studies medication response. And so there's a real need to look at clinical knowledge, next slide, as well, in part because different people respond differently to the same drugs. And for rare conditions, sometimes the only way that you know whether or not there is atypical medication response is by consulting with clinicians that specialize in serving a relatively small patient population, sometimes too small to see an adequate peer-reviewed literature on subgroups and atypical medication response. So in the absence of a process that uses condition-specific metrics rather than qualities and accounts for clinical knowledge, not just knowledge in the research literature, we see people with disabilities at a severe disadvantage. Next slide. Next slide. So I'm going to hand things over to my colleague, Sarah, who's going to talk a little bit about some of the ways in which the quality adjusted life year is being promoted in the United States and some of the problems that are materializing as a result.
Thank you, Ari. That's very, very helpful, and really appreciate all of your hard work to help us stay educated and to help us understand, you know, as background, Ari has been a real champion in helping us understand the quality from an academic standpoint, because I think it's important if you're going to engage in these issues of value assessment to really understand the metric and to be able to talk about it in audiences, you know, particularly in academic audiences. So I'm going to talk a little bit now about what is the Institute for Clinical Economic Review, because when we talk about the quality, we often end up talking about ICER. ICER conducts cost effectiveness studies for insurers using the cost per quality methodology that Ari just outlined. But now they have a new emphasis on first-in-class therapies. And so a few that they have done in the past in the rare disease space include spinal muscular atrophy, cystic fibrosis, tardive dyskinesia, and this retinal disease, which I'm not going to attempt to pronounce correctly. And then also, you know, ICER, we're keeping an eye on what they're doing. Just in the last week, ICER announced a new slate of projects for 2020 that include a blood disorder, cystic fibrosis, hemophilia A, multiple sclerosis, sickle cell disease, and wet age-related macular degeneration. All very rare, all rare diseases or for small populations. And so I want to talk a little bit now about ICER's evolution. We've come to focus on ICER specifically because they are well-funded and they're very active. ICER was founded in 2006 with significant support from large insurers that wanted to use cost-effectiveness analyses to help them make benefit decisions. So then 10 years later, we see ICER referenced for the first time in a government rulemaking to potentially be a reference for how drugs in Medicare Part B would be covered and paid for. Fortunately, advocates fought back against this, and that proposal was never implemented. Then in June of 2017, ICER announced a partnership with the Veterans Administration to inform their formulary development. And soon after, the Arnold Foundation gave ICER a $13.9 million grant. With that money, you see ICER then go on to be referenced for the first time in a state Medicaid program in the state of New York in particular to set a value for a cystic fibrosis drug. And then CVS Caremark intended or planned to use ICER. They wanted to set basically a $100,000 cost per quality benchmark for what they would cover in the future. But because there was some pushback from patients and people with disabilities, they're still at the table with those groups, trying to talk about alternatives and things that we can do that are different. So I think thankfully CVS hasn't moved forward on that, but certainly gives us pause. But what we know from all of this is that ICER studies are being seen as credible by payers and some policymakers, and ICER is actively conducting about 8 to 10 assessments a year. Advocates have long pushed back on ICER using the flawed methodology outlined by Ari. So specific to rare disease, in 2017, ICER created a new ultra-rare category of diseases with patient populations of less than 10,000, a classification which does not correspond to any accepted definition of rare or ultra-rare diseases. When they were revising their framework for rare diseases, they drew opposition from organizations like the National Organization for Rare Disorders, NORD as you would know it, and others who worried about the implications for coverage and incentives for innovation. As patients and families affected by rare diseases, it's imperative that companies invest in treatments for these conditions. And for many of these conditions, there are no current effective treatments, and they tend to impact small populations. The Orphan Drug Act recognizes that innovation needs to be incentivized for rare diseases. Yet ICER's model uses a short-term affordability threshold in its framework. And so this sets a threshold for spending on all new medicines, regardless of the patient populations or burden of the condition. ICER's methodology relies on what they determine to be a suitable budget, with little consideration for potential savings as people get healthier, not to mention our moral and ethical obligation to take care of people. And so the potential to stifle innovation, I think, is something that's very troubling. So we already heard Ari talk about the quality methodology and how it results in discrimination, but it raises even more ethical concerns when it's used in association with rare disease treatments. As was articulated by an advocacy group called the AIMED Alliance, when using a quality, people with rare diseases appear to be worth less than those with common diseases. We also worry about ICER conducting premature assessments. A significant point that patients and people with disabilities consistently comment on to ICER is that their assessments are premature, happening at or even before a new drug comes to market, using only the limited information available from pre-market clinical trials. And so their reviews are viewed as hasty and based on early assumptions, oversimplified models, incomplete data. Yet ICER does not consistently even update its reports with new information once that information becomes available down the road, making this haste to construct a cost-effectiveness model even more challenging, because you're basing the results on clinical trials in ultra-rare conditions with insufficient knowledge of the effect on the surrogate endpoints that will translate into the effect on clinically, and the way that it was stated here is will translate into the effect on clinically relevant endpoints such as morbidity and mortality in the long term. So we worry about these points, and the Plasma Protein Therapeutics Association made a similar point when they commented back to ICER on their rare disease framework. So when we talk about ICER, we often talk about their failure to meaningfully engage patients or consider outcomes that matter. What I don't want this to leave you with is the idea that you shouldn't engage, because absolutely many patient organizations have found it constructive to engage with ICER to improve the modeling and to improve the outcome. It may not, it's still imperfect, but it's certainly something that we want to encourage folks to be engaged in. But that being said, we're going to hear more today too from Siri Vyeth, who has been through this process herself. But we do worry that ICER doesn't necessarily incorporate the feedback that they're getting from patients. And it's frustrating that they don't necessarily include patients, caregivers, and clinicians who have firsthand experience with the condition at hand as voting members of the committee. So the folks that are voting on what the value assessment is are intentionally not people who either have the disease or treat the disease. So you saw this comment made by Cure SMA that their analyses was weakened by its lack of patient perspective and is different from current approaches in the drug approval process, particularly FDA, NIH, the 21st Century Cures Act. And going back to what Ari said, and Cure SMA, I think, stated this very nicely, that patients report a great value in any ability to improve their independence and activities of daily living. So we actually did a study on this issue as well to sort of put some numbers behind the extent to which ICER incorporated patient input. And as you will see by this chart, patient advocates typically had their input incorporated into ICER studies about half the time as other stakeholders. But on a positive note, as a country, our policymakers have routinely taken a stand against use of quality-based value assessments to determine how healthcare will be reimbursed and covered. So the Affordable Care Act explicitly prohibited PCORI from using the cost per quality to determine effectiveness, and further restricted its use in Medicare to determine coverage, reimbursement, or incentive programs. Even as far back as 1992, HHS rejected Oregon's prioritized list of covered services for Medicaid, citing the potential for violating the Americans with Disabilities Act due to the use of qualities and cost effectiveness. In 1992, this was so controversial that the former HHS secretary under the first president, George Bush, made the point in an opinion piece in the New York Times after he got apparently significant pushback for making Oregon revise its Medicare waiver application. He said that Oregon's plan in substantial part values the life of a person with a disability less than the life of a person without a disability, and that this premise is discriminatory and inconsistent with the Americans with Disabilities Act. And then he goes on to say that he thought that Oregon would have been sued over it as a violation of the ADA. So why do we care? Why do you care? So if you look at Medicaid access, which oftentimes is relevant for the disability community in particular, and oftentimes in the rare disease community as well, if we were to reference ICER's opinion about the value of treatments in Medicaid, 42 to 99% of patients with psoriasis, multiple myeloma, non-small cell lung cancer, multiple sclerosis, and rheumatoid arthritis would have to switch to a more cost-effective treatment. The results are especially bad for MS and rheumatoid arthritis, where most patients would have to switch their medication. This study only focused on those particular diseases, but I think is relevant to other diseases as well. Another study looked at the impact on Medicare Part B in particular, the drugs that are provided under that benefit. If CMS had been successful in implementing their Part B proposal to reference ICER studies, more than half of beneficiaries with rheumatoid arthritis, MS, non-small cell lung cancer, and multiple myeloma would have lost access to their prescribed treatment. So one place where we're seeing this actually play out also is with veterans in the military. The VA is referencing ICER, which seems to be influencing its formulary. The Department of Defense is also considering policies that could provide TRICARE with more authority to not to cover drugs that a group such as ICER would determine to be low value. So we're watching the DoD issue pretty closely because they have not yet implemented that provision. But the VA is absolutely moving forward with using ICER as a reference for their formulary. So in terms of federal policy threats, other ones that I wanted to make everybody aware of, we really are worried about ICER gaining a foothold and being the arbiter of value, at the administration level. The administration and Congress are considering policies to reference the prices of drugs in other countries that rely on quality-based value assessments or similar metrics that are based on averages. We often hear Tony Coelho, our chairman, say that no patient is average. The House is also considering a concept called binding arbitration that would most significantly impact rare diseases that have no other treatment option and would potentially use ICER studies to determine their value. States are also looking to reference ICER in their Medicaid programs. So I'm going to focus on this slide a little bit on the International Pricing Index proposal that is out there. You've probably heard that this administration is talking about bringing drug prices down to what other countries pay. The challenge is that other countries then just don't provide access to drugs that don't meet certain standards for value. The result is significant delays and barriers to patient access and worse outcomes in diseases where drugs really make a difference. So in one example that we talked about on our website, an adult patient with SMA in Australia was unable to get Spinraza because he was too old. The government had decided that it was only cost effective for children. And in many countries, treatments for cystic fibrosis have been denied. So if you follow PIPC, we have a website, pipcpatients.org/access, where we often talk about these particular examples from overseas. But I think when you hear about the International Pricing Index, something to keep in mind is to always ask the question, how is patient access going to be protected? So you might be wondering, based on what we were talking about with the state of Oregon, how states would even be able to move in this direction, which is a question that, frankly, I have too, and I think we've all been scratching our heads on. But the short answer is that, in a nutshell, it's because this administration has opened the door to allow states to limit formularies based on cost effectiveness. We saw it in the president's budget. CMS opened the door in its response to a proposed Massachusetts waiver application. And most of all, New York is already there. Despite significant opposition from New York advocates, their legislature gave explicit authority to its Drug Utilization Review Board to use studies from groups like ICER to establish a target price for drugs and not to cover drugs that cost more than that. So Massachusetts is now looking at that New York model, though there are many patient and disability advocates there working against it. We also got wind this year that California's Legislative Analyst Office has recommended the New York model to the California legislature, though it has not been taken up by them. But we do hope that you will help us track other states where they may be considering similar policies so that we can make sure that we're doing appropriate education. So finally, I wanted to just give everybody an overview of what we're calling now Value Our Health. Value Our Health emerged out of the significant and growing concern about proposals that would take decisions about treatment and care value away from patients and doctors and put them in the hands of insurance companies and government agencies. So leaders in many of these groups have direct experience with studies like those conducted by ICER being misused To elevate our community's voice, we came together to collaborate on a set of shared principles for value assessment that we hope to use to create or to educate policymakers and the public on what a patient-friendly value assessment should look like. We need to acknowledge, obviously, that patients are different and not allow misuse to limit patient access. We want these value assessments to be transparent, to engage patients and providers with firsthand expertise, and to rely on a range of evidence, not just clinical trials, and also to include the costs and benefits for real patients. We also want to encourage new evidence on value of treatments for patients. And we want groups like ICER to shift to doing more of this and to being supportive of this kind of value assessment. So last but not least, from me, we want you to advocate. We want you to, if you are willing to join Value Our Health, put your logo on those principles of what good value assessment looks like. Educate others. Try to hone in on why your payer may not be covering something. Remind your state and federal legislators that using QALYs to determine coverage discriminates. I think together we've found that ourselves making a real difference by educating and helping people understand how the QALY metric inherently discriminates. And I think being able to provide that kind of education to your state and federal policymakers, and as well as to your insurer, can be very useful. So I'm now going to turn it over to Siri. Siri, are you, and Daniel, are you able to give her control over her slides? Or
I am here.
Great, thank you.
Let's see. I'm hoping my slides will come up.
No worries. Well, we're very excited.
I just have a few.
Well, we're excited to have you here because you actually have a very personal experience being engaged with ICER in an ICER study, and that makes all the difference. And I think that personal experience can help folks who may see an ICER study coming down the pipe.
Well, thank you very much for including me on the panel. I am honored. And my name is Siri Bates. I am the Executive Director of Cystic Fibrosis Research Incorporated, or CFRI. I'm also the mother of Tess, who's a young woman with cystic fibrosis. And in terms of our organization, we fund research, we provide educational programs, psychosocial support, and we do a lot of advocacy on the state and the federal level. And just, quick summary about CF, cystic fibrosis. It is a rare disease. It's genetic. It impacts 30,000 people in the U.S. And most people think of CF, if they know anything about it, as a lung disease. And indeed, that is the primary cause of death for people, is progressive and fatal lung disease. But really, it is a systemic disease. It's an issue with a CFTR gene mutation that causes thick, sticky mucus to block all the tubes in the body and leads to many health complications, from lung disease to pancreatitis to diabetes to sinus disease to osteoporosis to diabetes to liver disease to chronic pain, sterility in men. And it's an extraordinarily complex disease. Making it more complex is that it isn't one single mutation that causes what we refer to as CF. There are now around 2,000 identified mutations. And this is relevant in terms of the new medications that are currently on the market and also in the pipeline about mutation-specific medications. People with CF spend hours and hours every day dealing with their health. There is not a day off, and it's respiratory therapy, multiple medications, lung infections, which exacerbations are very frequent and lead to very costly and painful hospitalizations. And as with many rare diseases, it is an extraordinarily capricious disease. For those who do end up losing lung function, their only alternative for survival is a lung transplant. Many people do not survive the wait for transplant, and for those who do, it is a whole other, there are many other health complications. Lung transplants are complicated. It's the only organ, it's open to the world once you have this transplant, very prone to infections. So we can move to the next slide, please. I wish that I had heard Ari's presentation and seen those slides before I engaged with ICER. So thank you, Ari, again, for that amazing overview. And Sarah, thank you. This would have been really helpful. So I'm optimistic for anyone else in the rare disease space who's about to face any kind of interaction with ICER. But, you know, strongly just from my personal and from a CFRI standpoint, and really on behalf of the other CF organizations that we partner with, you know, the key thing when I think of ICER, the word self-ordained is what comes to mind. They came out of nowhere. They're highly funded. And as we all know and just heard, their analysis benefits those who pay for medications. It has nothing to do with any patient-centered model. I'll speak to in a moment about the claims of transparency and inclusion and how that was really not accurate for our disease group. And that, again, I don't know why. You saw that list. They're circling back to cystic fibrosis again this year. I don't know why they are so focused on rare and now this weird definition of ultra rare. But really, it has absolutely no place with their analysis. And I really, from my interaction with ICER, it is a willful disregard to experience or hear or learn from the patient experience. Next slide, please. So those, I don't know how many people are participating and listening in, or people who may watch this later, but just so that if you don't have, really, if you're not that familiar with the rare disease space, I mean, the statistics are horrible. 7,000 rare disorders, with more discovered every day. 1 out of 10 Americans is living with a rare disease. And the technical definition of a rare disease is one that impacts less than 200,000 people. Most of them are genetic. Half of those affected by rare diseases are children, and 30% of these kids will not live to see their 5th birthday. And that for children in their first year of life, rare diseases are responsible for 35% of the deaths. And people often tout all the wonderful new drugs in the pipeline, and yes, there are 500 FDA-approved therapies and nearly 600 in the pipeline. But if we do the math, even if all 600 make it through, that's only 1,000 medications when there are 7,000 types of rare disorders, most of which I would assume, like CF, require multiple medications for health management. So nearly all of the current rare diseases have not one single FDA-approved drug treatment. Next slide, please. So CFRI's experience with an ICER review of CFTR modulators happened. CF, as I said, fatal lung disease, really a steady decline in lung function each year. If you look at charts, some people end up having a spiral with rapid respiratory failure. But lately, we have had significant advances. We are, in some ways, one of the fortunate rare diseases in that we have had new drugs coming down the pipeline. And so when CF was first, identified as a disease, kids rarely live to 5. By the time CFRI, my organization, was formed in the 70s, kids were barely making it through their teens. Now, the median age of death is 30, but kids who are born today and can take advantage of these new therapies are projected to live into the 40s. So why have we had this wonderful advance? It's because we have these new CFTR modulator drugs. And this is, it's not a cure for cystic fibrosis, but it really does address the root cause of CF. And these drugs are mutation specific. So as I referred to before, there are almost 2,000 mutations. So when these new drugs really help specific mutations. Full disclosure to anybody listening, my daughter, Tess, is actually on one of these drugs. And I would say her experience is similar to many others in that prior to starting this drug, she had had 3 significant lung exacerbations in 18 months, and each one required multi-weeks of IV antibiotics. She was in horrific health. She had to do hours of respiratory therapy per day and had to actually withdraw from college for a semester because she was too ill. She started this drug. She went 3 years without an exacerbation, which was just the first time in her life. So that was my experience. It's the experience with many others. And the key thing with CF is that you have an inevitable decline, and these drugs, for many people, stabilize the loss in lung function or add a little bump to it. And as a very well-respected pulmonologist said when assessing these CFTR modulator drugs, really as a pulmonologist treating people with CF, if you can flatline lung function, that is a significant win because it is usually the alternative. So when ICER approached the company that makes these drugs and asked them, said, we're going to be doing this review, and who should we talk to, because we're really into inclusiveness and transparency. And so they were actually provided with a list of names. There are many CF-related organizations in this space, and but we never, at CFRI, never heard from them, didn't see any emails, didn't have a call, and quite frankly, this was 2017, and they were not on our radar. And so by the time we heard that they were doing this review of the drugs, it was 1 or 2 days before the deadline for public comment. So of course we jumped in and wrote a very passionate letter on behalf of the CF community, and then received our thank you, and that was it. Well, then they released their draft evidence report. And it was such an unbelievable slap in the face to read this report, in which they, identify all the benefits to this drug in reducing exacerbations, but then does this analysis of, well, if a person has 4 exacerbations in a year and each of those is a hospitalization and the cost of that is XYZ and it's reduced by 50%, you're only saving this much money. And see, now let's look at the cost of transplant. And it's so horrifying, as we've said, and we will keep saying, there is absolutely no humanity in this analysis. And there is no accounting for the pain and the suffering. And to have this straight, well, geez, are you going to actually nearly die and have a transplant? Hopefully. I still don't think it's worth it to have this medication that could prevent that because it's expensive. So it was horrible to read the report, but speaking to the issue of transparency, what really infuriated CFRI and Emily's Entourage and Rock CF Foundation and the CF Lifestyle Foundation and the Vanell Foundation is that we were all listed as having been consulted with, and that they had received input from all of us in making their considerations for this report. And I contacted all my peers and I said, I don't know about you, but I did not receive anything from them. Did you? And the answer was no. So we felt like we were being listed as that they had consulted with us and to provide legitimacy to this report. And we were thoroughly 100% opposed to the findings of that report. So the next step for this report was then to have it be reviewed and voted on at the Midwest Comparative Effectiveness Public Advisory Roundtable, which is meeting in St. Louis, Missouri. And so we felt so strongly about this issue that CFRI supported my flying out to St. Louis to testify at this, to present at this hearing. And, I went on behalf of CFRI, I went on behalf of my daughter, I went on behalf of all my CF-related groups from the Cystic Fibrosis Engagement Network to just at least be on record that we did not support this report and that, quite frankly, it was a sham to say that we had anything to do with any input. So for anybody who gets to that level with their disease group, I just warn you, it was the most painful and dehumanizing experience imaginable for not all involved, for all involved who had anything to do with cystic fibrosis. And parents spoke, patient advocates spoke, individuals with CF spoke, a father who hadn't been able to even pick up his young children, who really was on the verge of transplant and thinking his young children were going to grow up without a father, who since being on these drugs has been able to work and pick up his kids and really sees a future with them. I mean, there were these story after story, incredibly moving. And let me just set the stage. The microphone that we walked up to make our presentation faced the backs of the committee. The committee was set up in a U-shaped form facing the opposite direction of speakers. And I will say some did not even deign to, pay the respect to turn their bodies around in their chair to look at us as we were presenting. And we were told we had 5 minutes to speak and that we'd be cut off if we went over. And it was extraordinarily painful. A lot of tears in the room for people who live with the disease. So then we sat through this incredible breakdown of the cost benefits using all the references, the methodology that Ari just presented, and it was incredibly absurd. It was flawed on so many levels from the reasons Ari has already spoken to, but literally for us, they would have the cost of an exacerbation. And I would think, in what universe in the United States of America is the cost of a 2-week hospitalization that number? They were not accurate at all, and they did not take in lost wages, underemployment, pain and suffering, mental health complications. I mean, there's so much missing from this, but really, ultimately, the biggest thing that's missing is the humanity. So we were literally squirming in our chairs through this hearing, listening to sitting next to a man with CF saying, wow, that's my life. That group there is right there deciding how much I'm worth as a human being. And another thing that I don't know was mentioned, if I missed it, I'm sorry, but part of their analysis was so flawed is they were doing all these projections for the cost of these CFTR modulator drugs that went into like eternity. And the goal for everybody is that this is what is going to keep people alive now, and that all the innovation that's going on, this is not a permanent treatment. So even then, to use numbers that project out into far into the future were not realistic at all. So in the end, we had all this moving testimony. They then have a whole voting discussion where they first go through all the measures of effectiveness of the drug they're reviewing. And during this process, they really did point out the improvements in health, the reduction in these expensive exacerbations. And they said that these CFTR modulator therapies, combined with best supportive care, substantially improve patient health outcomes compared with best supportive care, and provide other benefits such as reduced caregiver burden and new options for patients. So they went through that, and I'm thinking, well, I'm not optimistic they're going to change their tune on this drug, but I think maybe the committee will start spreading out in terms of their votes on the effectiveness and cost effectiveness. But in the end, they concluded that the cost of these therapies exceed cost effectiveness thresholds and basically were not worth it. And it was a unanimous vote. And all of us in the room who live with this disease were just felt flattened by it. And I just have to say, when it was over and I'm standing outside the meeting hall waiting for my Uber to go to the airport, and one of the people on the committee came out and saw me and thanked me for my testimony. And then she said, well, that was fun. And I just thought, that was fun. Okay, that just summed up the whole day in terms of the absolute disconnect between an ICER analysis of these drugs and their impact on our communities. So next slide, please. So going at it the next time around, and clearly from what you saw, we are all, as the CF community, about to step up to the plate yet again. Things that I have learned or that we would do differently, or advice I would have to any other group that's going through this. First of all, I really wanted to put up a photo from the Wizard of Oz, but I was very concerned that PIPC would have issues with the copyright. But that quote, "Pay no attention to that man behind the curtain," that is what I think of when I think of ICER. It's this bluster, backed by huge amounts of money, but they are self-ordained. And I think in the beginning, there was this sense they were intimidating, and that we didn't want to bring too much attention to them because that would give them credibility. And I would say my opinion has changed completely. We want the attention to be on them because we want people to understand how flawed this methodology is. Ignoring them is not going to help. So the other thing, we were already positioned this way, but to other groups who might be not established the same way, and many rare disease groups are extraordinarily small. Make sure that your organization is really ready to take policy positions and actions so that you collectively can move forward as staff addressing these issues, and really have a person in your organization who is the point person and paying attention to what ICER is doing. In the past, again, not wanting to give too much attention to ICER, I have a completely different theory now. Educate, educate, educate your elected officials. Talk about the rare disease community. They tend to have more responsiveness to their constituency and those who live with rare diseases. And then always, always stress that ICER's analyses of all these drugs, it isn't just inconvenient or, oh, it may cost something more at the pharmacy. It could literally have fatal implications if people do not have access to these therapies. It's their reviews and the way people are going to use them and have been using them will literally lead to people suffering and dying. And again, I just want to go back and study Ari's slides, but really point out their flawed methodology clearly and repeatedly. Next slide, please. So make sure you're informed so you know if ICER is deciding to make your rare disease drug at the focus of its microscope, and don't ignore calls for input. Conversely, really pay attention to how they use your name, because we all felt so violated that we were listed as if we had given them credibility for the results of their report. The other thing I really want to stress with other groups, you don't have to be an expert on drug pricing. A lot of people, when they come to, well, why are the drugs so expensive? And my role as the head of CFRI and the advocacy I do is about making sure there are no barriers to access. People need these drugs. And it is not my responsibility to have a whole analysis of drug pricing. And I think some people feel stressed by that, but they really need to be able to speak to that directly and stay focused on the mission, which is access. And then rally your community. We are really lucky at CFRI that we're part of the Cystic Fibrosis Engagement Network. We have other CF-related nonprofits, the ones I mentioned before, and we work closely together, but also rally your community using every method you have. Flood ICER with letters. If I had known this before, we would have had so much more heat and attention going to ICER, and also people who are watching this review. And bring in the media. We did bring in the media after their meeting and posted it, sent it to any health-related media outlets, posted links on social media. We want people to understand how flawed that is, and just keep informed and be nimble and prepared to respond. I don't even know if I have another slide. I think I just said thank you. So that was our experience with ICER. Again, I feel like we learned lessons that we will absolutely be applying in the next round, which is, according to ICER, happening in 2020. So thank you.
That was great. Thank you so much, because that is your personal experience, I think, is the most insightful thing that anybody can get out of this. So I really appreciate it. Christina, did you have any reaction to that from Everylife's standpoint?
Yeah, absolutely. Thank you so much for including us on this webinar. It was really informative for me to hear, the history of what's happened with ICER and the example that, Siri just provided for cystic fibrosis. Our rare community, as Siri had delineated, we know of 7,000 rare diseases right now, but they're growing every day. I think many of you know I'm here at Everylife because my own youngest daughter has a very rare genetic disorder. And, in addition to trying to get treatments into the hands of patients faster, because as Siri said, 95% of our patient community still does not have an FDA-approved treatment. The other barrier we're seeing is diagnosis. So one of the challenges is even trying to get insurance companies to provide coverage for diagnostics. And so I know my own journey just last year, despite having a platinum insurance plan, the wonderful doctors at Children's National spent far too much of their time just seeking coverage for, basic things like a chromosomal microarray. My daughter was diagnosed using whole exome, which is a test that looks at all of the coding regions of the genome, and we never received coverage for that. whole genome, which is the sequencing of the entire genome, is really, the future, likely future standard of care. And that, of course, there's not coverage for that either. So it's quite a challenge. Many of these kids, as all of you in the disability community know, if you're diagnosed sooner, you're able to get that early and intense intervention that is so critical and can be the difference between the ability to walk or not, the ability to talk or not. On the other hand, many of the patients in our community have degenerative diseases, and also, as Siri pointed out, they're dying, and they need treatment, they need them faster. We are at this point most concerned with the health and wellness of our patients. We understand that the pricing can be a challenge, yet we think there's got to be a way for society to work together and figure it out. So, again, thank you for all of the information. One of the things that I was most interested in and kind of relates to our ongoing efforts right now, you all had mentioned, the prematurity of some of the assessments that ICER is making. I think that was Ari, and, not, or doing things too quickly so that you can't take in some of the clinically relevant information you would get, say, from surrogate endpoints. This is an issue across the board with rare diseases, and we actually have coming up this September a scientific workshop here in Washington, D.C., and it's going to be looking at the science of small clinical trials in the age of biological plausibility. And one of the big issues we're going to be addressing with FDA, so Janet Woodcock, Peter Marks, Dragos Roman, Wilson Bryan, and Janet Maynard will all be in attendance, and it's really more of a conversation, this workshop, but we're going to be looking at how can we gain acceptance for the use of biomarkers as surrogate endpoints when it comes to rare disease treatment. And then the other side of the issue for us is small clinical trials. We've been using randomized controlled trials as the gold standard for 50 years, but the science has advanced and the world is changing. Many of the rare community members, they have small, heterogeneous patient populations. The traditional clinical trial design doesn't work anymore. It's not fair to randomize dying children to a placebo. So there are alternative models out there, and we want to identify them and obtain acceptance. And the other big piece that I think it was already touched on was the big mistake ICER has made in its failure to meaningfully engage patients. At Everylife, this is the core of everything that we do. And my colleague Shannon Von Felden, I know, is listening in on the webinar as well, and she leads our Rare Disease Legislative Advocates Program, RDLA, and this is the program that empowers patients to change policy and to have their voices heard on Capitol Hill and in their districts, in their state legislatures, et cetera. And many of you joined us earlier this year in February for our Rare Disease Week on Capitol Hill. We are already starting to plan for 2020. I hope you all can join us, but in the interim, coming up next month is our Rare Across America program, which is a second touch that we have to members of Congress as when they're home for recess in August. So that program will run July 29th through September 8th, and it will be for advocates to meet with their members of Congress when they're at home in their districts during the August recess. So if that's something you're interested in, please do reach out. We also have this week coming up our monthly Rare Disease Legislative Advocates webinar, which is a forum where we ask leaders in the patient community to provide updates on issues of importance, legislation of importance to the rare community. And that reaches leaders across the board in hundreds and thousands of different patient organizations. So that'll be at noon this Thursday, and we do invite people who are local in Washington to join us in person. We do provide lunch, and it's once a month. We also have a webinar coming up next week about Rare Across America. So that's all available on our RDLA website, which is rareadvocates.org. Another big area that we're focused on is through our membership program, which is our community congress, and it's very unique to Everylife. A lot of organizations have corporate councils. Everylife has found that there's a different model that works well for us. So Everylife Foundation, we set our policy priorities every year in conjunction with our board of directors, and they are solely focused on the patients. We do, however, believe that you can move the ball forward faster if you have the right partnerships in place. And so when we can collaborate, for example, with our industry partners, we try to do that. So the Community Congress is comprised of 3 working groups: public policy, regulatory, and newborn screening. And each working group is co-chaired by a patient leader co-chair and an industry co-chair. Now, all patient members join for free. Industry does pay to belong, but the goals of the Community Congress are set by the membership of the Community Congress. So when there's an opportunity for patients and industry to work together, we do. If we don't agree, we don't choose those issues to move forward on with Community Congress. But this year, the priorities that were chosen by the Congress for public policy is they're pursuing a $1.5 million appropriation for the National Academies of Engineering, Science, and Medicine for a burden study. So we want to do a study, a comprehensive study of the overall economic and societal burden of rare disease in the United States. So that's what that working group is focused on. The regulatory working group, they provide comments and feedback on FDA issues throughout the year. They also are pursuing a Center of Excellence for Rare Diseases modeled after the Center of Excellence on Oncology. The Newborn Screening Working Group, of course, is very focused on the ongoing reauthorization of the Newborn Screening Saves Lives Act, which was just passed by the House, by the House Committee of Energy and Commerce earlier today. They had the markup. And the Senate bill is expected to drop this week. So that's something that we've engaged with quite a bit with the March of Dimes and other patient partners. So highly encourage you to reach out to us if any of those programs are of interest. And thank you again to PIPC and to Sarah and to Thayer for raising this issue and for making sure we're all aware and engaged.
That was a lot. Christina, you guys are just doing so many wonderful things. If you want to, if it's appropriate, would love to get maybe a list of some of the things that you referenced that we could maybe then share with the group that is on the webinar.
Oh, absolutely. Yeah, we'd be happy to.
That would be great. And also, would love to have PIPC sharing that information more actively as well, because you guys are doing some great work, and I really. In particular, I know I've told you this before, but I think the burden study that you're pursuing is just so important. It really does get to the issue of what matters to patients and what patients are experiencing in their real lives. And I think that information will be very useful, particularly as, and not just in this context of value, but also just thinking about PCORI, the Patient-Centered Outcomes Research Institute, and NIH and other research institutes to think about what kind of research they need to be prioritizing.
Yeah, that's what we're hoping to do. And the other issue that keeps being raised is the importance of caregiving and the cost to families, not just, the direct medical cost, but the cost to the caregiver. And this is something that's been addressed a bit, but we've never gotten a number for rare diseases across the board. So I think that that's going to be pretty critical. We know lots of parents who are taking time out of work, have lost their job, are providing around the clock care, and that really starts to add up, as you all know.
Does anybody else have questions that they would like to submit? There is a Q&A icon on the Zoom technology if you look at the bottom of your screen. We would be happy to take a couple of questions before we wrap up. But I just want to say thank you to all of the folks who participated on the panel. Every time that we do one of these webinars or presentations, I feel like I learned so much. And And also, you know, to the extent that it is useful for your organizations, those of you that are participating, please always feel free to reach out to any of us that were on this panel, because we're always happy to participate in dialogues that you may having amongst your members to spread the word. And also we welcome suggestions that you may have about what we could be doing better in terms of how we educate advocates. One of the things I know that's concerned us as PIPC over the years is that we often, you know, honestly, we have been very inside the Beltway for a long time. And when the spite entered the states, in particular, when we saw New York taking action to reference ICER studies, and we recognized that states are considering these kinds of value metrics to be used in their Medicaid programs, we realized what a mistake it had been, that we haven't been more outside of the Beltway, that we've been somewhat insular. And we would like to make up for that. We really want to get outside of the Beltway and help advocates in the states and locally to better understand what these issues are, what is a quality adjusted life year, why people need to be concerned, and then provide tools to push back and engage on these issues as well. But the only way to kind of, you know, to get your local legislators educated is to be in their offices and doing it personally with a seat at the table. And so anything we can do to be providing those educational materials, we're absolutely happy to do. So I see a question, who exactly is ICER? And so just to go back and clarify, and we will share these slides too. This whole presentation will be put up on the website after it is complete. ICER stands for the Institute for Clinical Economic Review. It is an organization that conducts value assessments that is based in Massachusetts. It is an independent entity. It is not a government agency, but it does have significant funding. Originally, it was I think seed funded largely by insurers. Now it is mostly funded by a foundation called the Arnold Foundation. And with those funds, it conducts value assessments where they look at a cost per quality adjusted life year metric to determine the value of treatments, particularly treatments that are just coming to market. I hope that clarifies. I see another question about, is there an article about the experience of the CF group with ICER? Siri, that would be a question for you. Have you ever put together any materials or about your experience with ICER?
I've participated in podcasts about it, and then, you know, we did the press releases afterwards, but that actually is a great idea. And, you know, now that maybe being asked to participate in this panel would make it easy just to have something that would be a reference for other people. And I'm very happy to speak to anyone else who has questions for their group about our experience. So I think that last slide had my email address.
That would be, yeah, that's a great idea. If you go to valueourhealth.org, we do have some materials there. There's a document on that website under resources that specifically talks about 5 ways that ICER fails patients. The goal of that infographic is to really succinctly describe the flaws in ICER's methodology. So that might be something that is useful to folks when they're speaking specifically about their concerns about the methodology that ICER uses in their value assessment. And again, happy to, what we can do is when this is over, we will provide then links to some of the information that's been shared here on this webinar that may provide valuable tools for you to use in your own education.
And I think that's a great idea. This is Siri. Because there are some really wonderful articles about ICER, it would be great to have a little resource library. That's a great tool for everyone.
Great, we'll do that then for the meeting participants. Well, I don't see any other questions coming up, so we'll give folks back 15 minutes of time today. But I do want to just say thank you again to everyone, Ari, Siri, Christina. You guys are, really have helped us to hone in on our own advocacy, and hopefully together we can make a difference. And for others on the call, I hope that this was useful and helpful. And please know that we welcome feedback and suggestions.
Thank you for putting this together. It was an honor to participate.
Thank you.
Great, thanks to everybody. So we will end it here, and but please, once the link is complete for sharing, when we have it up on the website, we'll share it with the group. We encourage you to share it with others. Thank you.
Thank you, everyone.